Assalamu alaikum. I am Dr. Ibrahim Khalil from Dhaka Medical College. So today is a case about Brugada Syndrome. So I have no disclosure and no conflict of interest. And the case, 38-year-old male patient with influenza-like illness, fever and palpitation. He has few episodes of unexplained syncope, but he did not give any specific history how did that occur, but he did keep that episode of syncope, and also he is otherwise healthy and he has no comorbidities and he does not take any medication. So we did the EKG, and the EKG show specific Brugada type 1 pattern, and our diagnosis was Brugada syndrome. So actually Brugada syndrome was discovered by Pedro and Joseph Brugada in 1992, and the genetics of Brugada was also established by their another brother Raman Brugada in 1998. So they are the legendary Brugada brothers. So we all know about them, and in EKG we can see it like three type of Brugada pattern: type 1, type 2, type 3. In type 1 there is the cope type ST elevation, and which is more than 2 millimeter in, and this the type 1 is the only specific or diagnostic pattern, but type 2 and type 3 are the non-diagnostic patterns. So this is very important. And the genetics of Brugada syndrome, there are many mutations, but the most specific is the SCN5A mutation. But there are also other mutation can occur in the potassium and calcium channel. So the genetics is very complex, and many mutations are also still unfolding. And we can see that this is another slide showing the genetic mutation in Brugada type 1. This is the SCN5A mutation, which is the most common, like all of Brugada syndrome, 11 to 28% is the SCN5A mutation, and there are also like calcium channel mutation, like CSCN1C mutation, 6.6%. So this is also the second most common etiology. We can see the effect of SCN5A mutation in the action potential. So SCN5 mutation specifically cause the depolarization abnormality. It's cause the slope. It decrease the slope of the depolarization, and also decrease the duration of action potential duration. And especially Brugada syndrome and like early deposition pattern is now in Europe's journal. They call it the J-wave syndrome. They included Brugada syndrome early deposition pattern in that journal. And then we can see the SCN5 mutations. It can be associated not only with Brugada syndrome, it can be also associated with long QT3, the dilated cardiomyopathy, and myocardial contractile dysfunction, also in atrial fibrillation, idiopathic BF, sick sinus, left laryngeal syndrome, and many other causes. And there's some overlap also with SCN5 mutation. It can also be common with long QT3 and FE, sick sinus syndrome, and it can be modified by like genetic factors, age, comorbidities. And in our case, in this patient, it was aggravated by fever, and some patient can be aggravated by medications like sodium channel blockers. And we can see that in this we can see the genetic effect of SCN5 mutation. It can cause functional abnormality, and it can cause also structural abnormality, also like dilation of the RBOT, and it can be triggered by increased Pagleton, pyrexia, drugs, and electrolyte disturbances. Then these are the common mutations. It can also they share common mutation: Brugada syndrome, CPVT, long QT, short QT, they share common mutations. And now we come to the diagnosing part of the Brugada syndrome. These from the JACC state of the art review, and they said to diagnose for the at-risk patient, we see that if any patient suffered any syncope or ventricular arrhythmias, and if they are asymptomatic, then if they have any type 1 or type 2, 3 ECG, then we should do like initial evaluation, ECG, echo, and then we can do sodium channel blocking, propagation test, and many other things. So this is the ESC 2022 guideline. So their recommendation for the duration of time. I am skipping this. And also we can, to diagnose Brugada syndrome, we can use the high lead ECG placement. In standard lead ECG placement, we sometimes may not see the characteristic pattern. So this from the JACC journal, we can see that if we do high lead placement, like shown here, we can sometimes got the correct or specific pattern, which sometimes may not be available. And this is the sodium channel blocking propagation test. We can do azmaline, flecainide, procainamide drugs like this. This is the procainide propagation test. See the baseline EKG and see the procainamide and infusion EKG. Like there is a specific Brugada pattern after the infusion test, and this is also like adrenal provocation test. So see the baseline and the after infusion test. So this is the characteristic Brugada pattern. Now to the diagnosing part about the Shanghai scoring system, the Chinese physicians they suggested recently the Shanghai criteria. So the Shanghai criteria, we can see this, there must be at least one EKG finding, and if it's like more than 3.5, more or equal to 3.5, it is probably definite Brugada. But if it's 2 or 3, it can possible, and if it's less than 2 or less than 2, it is non-diagnostic. So this is the Shanghai criteria. We can see that the EKG findings, the specific or spontaneous type 1 ECG is 3.5. So if they have just spontaneous type 1 ECG, it's Brugada. But if they have type 2, type 3, or fever-induced type 1, then it's not, we have to include other findings also, like then the clinical history, if they have nocturnal agonal respiration or suspect arrhythmic. But that's the most important part is that, few minutes just. The most important part is that if based on genetic history or any other thing, they just give 0.5. Just so, this is the risk, we can see the high risk and low risk patient. This is also from Jack, and this is the annual risk in case of Brugada, like. And now the treatment part of the Brugada syndrome, according to the ESC guideline. So this is the algorithm, and for the sake of time, I'm skipping this, and just the few words about that. In treatment of ICND is only recommended if they are the survivors of aborted cardiac arrest or just had spontaneous cardiac arrest. And also if they have just spontaneous type 1 Brugada, it may be indicated this is a class 2A recommendation. But if they just have spontaneous type 2 or type 3 and after sodium channel provocation test and they are type 1 also, then the ICD is just there, less recommended. And we can also give quinidine as a bridging, or some, if they can't take ICD at that moment, we can give quinidine. And also catheter ablation is another possibility, but it is not recommended until we see the other advantage. And this is the another, which is very old, but is also, I want to point the last line that ICD is not indicated in asymptomatic Brugada patient or on just they have drug-induced type 1 or on the basis of genetic history alone. We can have to exclude the other history that they don't have any sodium channel blocking drugs. We can see that on the Brugada.org website that they have the many drugs that can cause Brugada or the Brugada pattern in ECG. So we have to exclude that they don't take any drug like that. And this is also another flowchart showing the indications of ICD in case of Brugada syndrome. And for the sake of time, I have to skip this. And thank you very much for the attention.
Thank you very much.